Hello there. Hi. Welcome to the webinar, everybody. We're going to make a prompt start, if that's okay, because we've got quite a lot for everybody to cover. Thanks ever so much for coming. Today our seminar is titled Practical Patency Valve. I'm Gemma Jones. I'm the chair of the Tracheostomy Sen. Just a bit of an introduction before we start. We thought it'd be useful to follow up on some of the PMV session we had with Kirsten King earlier in the year. And we emailed you all out for some kind of comments and questions and things you'd like to cover. So thanks so much for all of who got back to us. Of course, as all of these things are, we couldn't cover everything in today's session, but what we're going to focus on is we're going to focus on some of the myths surrounding PMV application in the ventilator circuit. And the plan is that we will follow up on some of the later themes or some of the themes that came up at later webinars, which we'll discuss a bit later. Before we go on, I've got a panel of amazing colleagues who are joining me today to help out with the webinar. I'm very grateful that they're here. So I'll just take some time if I can go around and let them introduce themselves to you all today. So I'll start with the top of my screen, which is you, Helen.
Hi, I'm Helen Newman. I'm a speech language therapist in critical care at Barnet Hospital and currently doing an NIHR clinical doctoral research fellowship.
Amazing, thanks. Brenna.
Afternoon, everyone. I'm Brenna Fossey. I'm the Head of Service and Clinical Lead for Adult Speech and Language Therapy at East Kent Hospitals.
Amazing. Sarah.
Hi, everyone. I'm Sarah Wallace, and I'm Consultant Speech and Language Therapist in Critical Care up at Wythenshawe Hospital in Manchester.
Thank you. Neve.
Hi, everyone. I'm Neve Winters. I'm the Speech and Language Therapist currently working on critical care at Manchester Royal Infirmary.
Sue.
Hi, I mostly work at the two ITUs at the National Hospital of Neurology and Neurosurgery.
Amazing, thank you. And Annalisa is with us, but she's currently winging it to a cafe somewhere in London. So she will be joining us later if she can. So she's currently there in spirit, but Annalisa will be joining us as soon as possible. As usual, before we start then, they'll all be recorded. There's an opportunity for you to ask questions in the Q&A box. Please type along and we'll try and get some time at the end of the webinar to answer these, and we'll upload our webinar today to our YouTube channel at the earliest opportunity. We're going to start a short presentation from Annalisa. She's pre-recorded it knowing that she would have challenges getting here first thing. So the sound is quite quiet. So please make sure that you've joined on computer audio and that your audio is turned up to its max, because there's nothing that we can do our end. But as I say, we'll be able to watch back. So we'll just hand you over to Annalisa whilst we've screen shared and stuff, who will be doing, as I say, the practical application of the PMV, so what we need to do to set up. And then she'll be covering the first myth as well, which is that PMVs lead to lung de-recruitment and increased work of breathing, which I'm sure we come across quite a lot in our clinical practice. So if Helen, you could start it up, that would be amazing. Thanks so much.
Hi, everyone. So I'll start today's short presentation / discussions by talking about a brief overview of passive valves in the ventilation circuit. I'll give you a quick step-by-step guide on the initial assessment and also give you some pointers and considerations along the way. In terms of patient suitability, it is all criteria as per speaking valve on non-ventilated patients. So I'm not going to go into the requirements around the tracheostomy tubes and disease specifics, etc. But I will talk about what's needed for specifically the ventilated population. I've highlighted some of the information on the ventilator here. So PEEP, according to most different guidelines, is recommended to be either 10 or below 10 centimeters of water. I have to say that there's no evidence base behind those figures. They are just numbers that have been pulled out, but we do have to start somewhere, so it's a guide. And if someone's PEEP is, if it's a larger patients with, say, obstructive sleep apnea on top of it, their own physiological PEEP might be over 10, so we can't expect their ventilator delivered PEEP to come any lower for the weaning purposes either. So it is, again, individual patients, and it's not a hard and fast rule by any means. Similarly, with fraction of inspired oxygen, the guidelines usually say 0.6, or if you use percentage, 60% or lower for speaking valve use. But again, I personally have used speaking valves with patients that are on 100% oxygen, but certainly in those cases, not for routine use of speaking valves or anything, but just for quality of life purposes, or, you know, to discuss a certain aspect of care or decisions with the patient where voice is desperately needed, then, you know, these are certainly the exceptions and can be implemented in discussions with the team or collaboration with the team. For pressure support, there are no maximum values that can be recommended. I know that different guidelines and different trusts have, you know, numbers. Some trusts say pressure support of 15 or lower. Some have different values. But again, these numbers have no evidence base behind them. They're just numbers out of thin air. Obviously, if someone's pressure support, the higher the pressure support requirements, the sicker the patients are. But I personally have used a speaking valve successfully with a patient on pressure support of 23 and just one lung and a stump leak on the other side. So again, it is very patient specific, and the numbers are never as important as the individual patient themselves. So definitely think about the situation, think about your patient and discuss with the team. So there's never a definite no when it comes to those numbers. And also another thing to think about when it comes to our ventilator patients is patient specifics. So thinking about fresh wounds in the area, so patients post ACDF or a very recent messy large leaks, surgical tracheostomy, obviously where the high flows coming from the ventilator are directly passing by these fresh wounds, then the risk could be subcutaneous emphysema. So just something to bear in mind, specifically to our ventilated population when we're thinking about commencing speaking valve use. But moving on to the steps with PMV insertion for our ventilator patients, and again, you know, you would do whatever you normally do, your cranial nerve assessment, your background information, all of the things that you would do for your non-ventilator patient, but specifically for ventilator patients. In addition, I can't emphasize enough the importance of patient education. So doing the usual patient education of talking about their tracheostomy tube, what it changes for them in terms of physiology. I'm talking about the cuff, how it impacts the airflow, talking about how we can deflate it, and then what happens, what would the patient feel, especially if they're ventilated, you know, the high flows then coming through an area where they haven't had any airflow through, that it's normal to make them cough, it's normal to make them even feel a bit sick or gag a little, to really, I guess, empower the patient with knowledge and let them know, you know, that they're in charge, that they're in control, that we can stop anytime it gets too difficult, because one of the main things the patient lacks in ICU environments is control. You know, everything is done to them and not with them. So really making them feel that they're a part of this process of trying to get them back to talking and perhaps eating and drinking by using the speaking valve, and making them feel like an equal partner or the most important piece of puzzle in this process. And obviously nurse education is very important, or whoever you're doing the assessment with, ensuring that they are fully aware that there will be no expiration back into the ventilator once we put the PMV in line, and that by the ventilator alarming and telling us that there is no expiration, it doesn't mean that the patient is not breathing. Then moving on to upper airway assessment, so looking at expired tidal volumes prior to cuff deflation. So if the patient is someone that's not on full mandatory ventilation and they're taking their own, initiating their own breaths, therefore deciding the size of the breath themselves, then it's necessary to look at that expired tidal volume over 30 seconds or so to get the average tidal volume. And I've just used a Marquez overview screen here as an example where those expired tidal volumes sit. Obviously different ventilators will have them in a different place, so get to know your ventilator and see where the values are that you need to monitor. So this, looking at the tidal volumes pre and post cuff deflation, is to replace the finger occlusion that we do on non-ventilated patients, because we do momentary finger occlusion to make sure that they're able to breathe via their upper airway, whereas on a ventilated patient we can't do momentary finger occlusion. So monitoring their expired tidal volumes is the way to assess their upper airway patency. And because we're getting numerical results, it's in fact a lot less subjective compared to finger occlusion. So once you establish the average tidal volumes before you even touch the cuff or suction them, you move on to, you know, suctioning their mouth and their trachea if needed, unless they've just been suctioned prior, and you do your slow cuff deflation. If you do your slow cuff deflation together with tracheal suctioning, then your upper airway assessment cannot continue immediately, because suctioning basically involves pulling air out of the patient's lungs, meaning that their expired tidal volumes will be much smaller immediately after suctioning. So if you do need to do tracheal suctioning, just wait for the patient to gain their tidal volumes, expired tidal volumes, before you proceed. So your upper airway continues once their tidal volumes are back to baseline, and you look at their tidal volumes again after cuff deflation. So looking at the same numbers here again, and you're wanting them to have dropped. So the expired tidal volume needs to drop by at least 40% for you to be able to proceed with PMV application. So if you think about, again, your non-ventilated patient where you do your momentary finger occlusion, you don't put a speaking valve in line on the patient unless you're certain that they can breathe via their upper airway. You also shouldn't be putting a speaking valve in line unless you're certain that they've got sufficient leak via their upper airway if they're ventilated. So this is very much an essential thing to do for us speech and language therapists, to assess their upper airway patency. So we cannot skip that step with our ventilated patients. And obviously, once you've put the speaking valve in line, your further assessment of upper airway swallow and communication continues, just like with your non-ventilated patients. You're looking at their secretion management to make sure that they're able to be safely continue with the speaking valve use. You're looking at their swallow and communication success, etc. But specific to ventilators is another aspect that I want to bring out, is how they're managing with the ventilator flows to make sure that the ventilator is not auto-triggering, and all that troubleshooting that may actually form part of your rehabilitation. But that sort of goes beyond the scope of the session today, and we'll certainly come back to it in our rehabilitation or therapy session that is planned for a later date. But to continue on that leak a little bit longer, so if your tidal volume, expired tidal volume, drops less than 40%, then that is your cue to go looking for reasons in their limited upper airway patency. So is it the tracheostomy tube that is too large, so that the patient is unable to breathe around that deflated cuff in their trachea? Or is it the tracheostomy tube positioning that's not quite right to facilitate breathing via their upper airway? Or is it the patient's anatomy and physiology that may be creating some increased resistance to the breath out via their upper airway? And also, if the expired tidal volumes drop a lot more, say close to 90%, then that's absolutely normal too. That's just indicating that there's lots of room for the air to travel up through their mouth and nose, but we need to be then prepared for the increased difficulties for the patient to cope with a large leak, because the ventilator flows can be quite heavy and quite high. So and the ventilator is therefore more likely to go into auto-triggering as well, and we need to manage that. I also want to draw your attention to this recent article that was published in the American Journal of Speech and Language Pathology that looked into different ways to assess for upper airway patency with speaking valve use. And I guess the question it poses really is monitoring expired tidal volumes sufficient, that we've just spoken about, or should we also use transtracheal pressure manometry plus minus other screening options to ensure we obviously had quite a lot to say about this area, so you can watch out for a soon-to-be published reply in that same journal from myself and Sarah, and also Peter Ekbergs, who's an intensivist in Holland and very much interested in the area. So keep your eyes open for that. And I also thought, although I'm not definitely by any means a specialist in the area, I thought I'd mention a few pediatric considerations as well for the ventilated population. So often the pediatric tubes are not cuffed, so therefore you can't monitor for increase in leak or increase in leak that's indicated by expired tidal volumes to indicate upper airway patency, because there's a leak there all the time and it's very difficult to quantify. And also often the children are too young to follow instructions, because we know that nearly half of children with tracheostomy tubes are under 1 year of age. If you do work with pediatric population, then I suggest you type that link into your search bar and find this brilliant article by our American colleague Laura Brooks. She talks about all these at length. This picture is also pinched from her article to highlight how we can use transtracheal pressure manometry in assessing for upper airway patency. And this one here is another picture from the internet that looks at it a little bit closer with all the components labelled as well. So if the pressures are too high or stacking up, then that is an indicator of insufficient upper airway patency. So whether there's not enough room around the tracheostomy tube, or there's not enough room through the airway above the tracheostomy for the air to travel up, and you shouldn't be using a speaking valve. I wanted to bring this controversial issue into my talk here too, of drilling holes into the PMV. So it's obviously, often comes up as a suggested thing to do in case the pressures are too high, but there is no evidence to suggest that, how you should go about it, or that it's, one way is safer or best to do. How big is the hole? How many holes do we need to have? So, and also knowing that the Patency valve especially is a one-way valve, a no-leak design valve. Once you drill a hole into it, it's no longer a one-way valve, because they can breathe out via the hole as well. It's no longer a closed valve, because there's a hole that can have leaks out of the whole time. So it really defeats the purpose of a one-way valve, really. So, it may be an option, but definitely caution needs to be taken. And finally, I thought about some practicalities for speaking valve use with mechanical ventilation. In order to put the speaking valve in line with mechanical ventilation, you need to put it as close as possible to the tracheostomy tube. But obviously, most mechanically ventilated patients have inline suction catheters in place. So the best place to put the speaking valve, and the most practical place to put the speaking valve, is on the side port of the inline suction catheter. And to put the speaking valve in line with ventilator in the first place, you always need to disconnect the closed ventilator circuit in order to put the speaking valve in line. So when you do so, the ventilator circuit always has secretions inside them, more or less, but always has some secretions. So make sure that you aim downwards with this tubing when you disconnect, because you have a nurse or a physio or another speechy colleague standing on the opposite side of you. And if you aim that tubing towards them as you disconnect or when you disconnect, then they're going to get sprayed with those secretions and the humidity coming from the tube, and they're not going to be happy, especially during COVID times. So put something on the patient's chest before starting, be it the humidity coming from the tubing, be it the secretions, or even vomit flying out of patient's mouth as you drop the cuff. It's great to have something on the patient's chest. Also, something to bear in mind is the different connection options depending on the vent tubing used. So for this particular case here on the picture, you can put the speaking valve directly onto the side port of the inline suction catheter equipment, but the licorice stick that follows does not fit over the speaking valve because it's a 50mm connection and the speaking valve needs a 22mm connection to go over it. So you need to have an adapter ready to go. There are 2 different adapters that Passimio, the company themselves, now produce and sell as well, but I'm yet to come across these in an NHS setting. But no worries if you don't have them. There are alternative options that are probably already available in the unit because 22 and 15mm, they're very generic ventilator equipment measurements. So you can definitely, most certainly find alternatives without the need to definitely go looking for those connectors from Passimio. But the main thing is to be prepared, know your equipment so that you wouldn't end up in a situation where you are ready to put the speaking valve in line for the patient and then realise that you can't actually connect the pieces together. And that is it for this session. Thank you very much.
So what we're just going to do is we're going to start sharing Annalisa's first myth section, so that lots of times people talk about using Passimio valves and that they lead to lung derecruitment and increased worker breathing. So we're just going to hear from Annalisa about talking about that. Helen, if you could share Annalisa's presentation, that would be fantastic.
When there is no airflow back towards the... So I'll start with the first myth, which is can't use the speaking valve on the ventilator because the patient's lungs will collapse. So what happens to the patient's lungs when we generate the leak in the circuit for Passimio valve use? Ventilator won't tell us much when there is no airflow back towards the ventilator. So as soon as we insert the one-way valve, the air can go only in through the valve, but nothing comes back out through the valve, back towards the ventilator to tell the ventilator how the patient is going. So often, therefore, there are concerns from the clinicians that the patient's lungs may collapse or de-recruit because we've created a leak in the system. Some of the air that's meant to go down to the patient's lungs is actually leaking up towards their upper airway and not reaching their lungs to support them sufficiently. So perhaps we're not providing them with sufficient ventilation. But what does research say? So for my own PhD, myself and the team, with great help from my team, we looked at what actually happens to the patient's lungs before, during and after speaking valve use. So we looked at the patients for an hour, so observed them with 15 minutes of baseline ventilation, then put the speaking valve in line for 30 minutes and decreased the ventilator delivered PEEP by 5 for that period, and then took the speaking valve off, put the cuff back up, put all the settings back to what they were, back to baseline ventilation for another 15 minutes. And we observed the patient with electrical impedance tomography, which is basically radiation-free, non-invasive, bedside real-time imaging tool of the air moving out in and out of the patient's lungs. You can see the EIT equipment next to the patient here with the EIT belt around their chest. And this is the main or first publication from this study that looks at lung recruitment, specifically aiming to, reply to that myth or bust that myth, if you may say so. So looking at this picture here, on the left-hand side, it shows you the tidal change with no speaking valve. On the right-hand side, it shows you the tidal change with speaking valve. The more colour you see, the more blues you see, or even when it turns lighter and white, it means that there's more air in the lungs. So at baseline, there's obviously a lot less and not much enters the lung with no speaking valve, but with the same settings with the speaking valve, even at baseline, there's a lot more, and maximum end of inspiration, there's also a lot more. So looking at the main results, we see that end expiratory lung impedance, which is, according to literature, highly correlated with end expiratory lung volumes, increased significantly throughout speaking valve use and increased even further after we removed the speaking valve. So, and percentage-wise, it initially increased by 19.7% for the first 15 minutes, increasing to 83.6% for the second 15 minutes with the speaking valve when the patients were talking, and then increased to 120% after we remove the speaking valve and return the patients to their baseline setting, so indicating a recruitment effect. And also SpO2 didn't change significantly, and heart rate didn't change significantly, but you can see that the respiratory rate decreased significantly, and end-tidal CO2 decreased significantly for the speaking valve period, and then went back to their baseline after the speaking valve was removed. So we concluded that in this cohort of critically ill ventilator patients, which was a cardiothoracic cohort, speaking valves did not cause the de-recruitment of the lungs when used in the ventilator weaning period, so busting that myth. And also we concluded that one-way valve use may in fact facilitate lung recruitment during and after speaking valve use. We went to investigate that a little bit further, looking at ventilation distribution with speaking valve, and also concluded that whilst de-recruitment didn't occur, as we said in the previous article, we also found that hyperinflation also did not occur with the speaking valve, that the ventilation was distributed evenly in the lungs, and concluded that these data, along with obvious psychological benefits to patients, are encouraging towards safe use of speaking valves in this critically ill cardiothoracic patient population. And also to speak slightly about increased work of breathing in PMV, which was a frequent question that was posed by the members, then I would say that it is not the PMV that is causing increased work of breathing, and I'll give you some considerations and tips to think about when you do come across a patient that appears to have increased work of breathing with the PMV in line. Are you sure that the upper airway assessment was done properly? Do they really have enough space, enough upper airway patency to use a speaking valve? Have you reduced their ventilator delivered PEEP? Because if you've restored their own physiological PEEP, plus you're delivering as much from the ventilator as you were before, then there may just be too much resistance to them breathing out, again, making it harder for them to breathe unnecessarily. Is the ventilator auto-triggering breaths? So have you managed to get the patient and the vent in sync? Is the patient managing the flow and coordinating the breaths? Is the patient perhaps anxious? Are they very excited, on the other hand? Are they frustrated? Are they angry? And, if they are very anxious, was the patient education provided prior that I mentioned during the intro talk, which is all very, very important towards patients feeling calm and relaxed about the speaking valve. What is their secretion management like? Is the patient tired? Are they being pushed too hard today with rehabilitation, weaning, etc.? Was the work of breathing perhaps worse to even start off with before you apply the speaking valve? So lots of things to think about, and it's never the PMV that is causing the work of breathing, it's the other aspects around it that need to be problem solved.
Fantastic. So that's the hopefully really useful information about work of breathing and lung de-recruitment. The next one we had as a question or a theme was that this idea that you can't use PMVs as there's too many secretions. And Sarah's going to take us through a whistle-stop tour as to busting that myth. Thanks, Sarah.
Okay, so I think the first thing to say is that it's really important that you understand why that individual patient has excess secretions. So usually it's multiple factors, but you need to think about cuff inflation itself, reducing lack of airflow, and also reducing the natural humidification that occurs through the obviously upper airway and nose, reduced laryngopharyngeal sensation as a result, and reduced urge to swallow, presence of an irritant, the tube itself. Patient may also have underlying neurological or bulbar issues, or may have had head and neck surgery, cranial nerve problems. Laryngopharyngeal reflux also leads to increased secretions and irritation, and obviously dysphagia, and sometimes hypersalivation, but not commonly. And obviously as well, secretions created by having respiratory infections, whether they're bacterial, fungal, or viral. So it's also really important that you understand and can distinguish between upper and lower airway secretions. Upper airway secretions tend to be thin, loose, watery, salivary. Lower airway are the ones that are thick, often And that's the ones where your physio colleague is very concerned about. When the secretions are thin and salivary, the passemeal valve is really helpful, isn't it? Because it drives airflow through the larynx and helps to expel secretions upwards when they're on a ventilator, and also to drive that sensory recovery and swallow response and glottic closure response. We do have some evidence for that as well to support that statement from various studies. There's a study by Lichtman in 1995, which found 40% reduction in secretion accumulation when using a passemeal valve. And another study that showed improvement to secretion rating scale when using a passemeal valve in 2012, which was reported at Dysphagia Research Society. And anything that produces airflow and is going to stimulate swallow and cough. We saw the same in our ACV study, which showed that you actually get secretions blowing up and increased swallow frequency and reduced secretion ratings. So passemeal valves help secretion management. You sometimes need extra things, don't you? You need a bit of support with medications to reduce the secretion burden, the saliva secretion burden. But if the secretions are thick, then I think it's really important that you make sure your patient's on a warmed, humidified circuit, that you may need to use mucolytics like carbocisteine to loosen secretions, that you're working with your physio when they're doing their chest clearance, so that you can work together to look at what's causing the issues, and cough assist to help mobilize secretions, and proper tube care. So is the tube circuitry being changed regularly enough? So all those things are routine care that can mitigate for having thick secretions, and obviously nebulizers as well the patient can be on, and regular suction. So those things can reduce the risk of things getting blocked in the tubing, thick secretions blocking a passemeal. So it's about proper care and about understanding secretion management issues. But to bust the myth, passemeal valves help secretion clearance and secretion management. Is that all right?
Amazing, amazing, Sarah. Thank you so much. Moving swiftly on to the next kind of thing that came up as part of your questions, and that certainly comes up a lot on the unit that I work with, the idea of overnight use and PMVs, which Sue is going to talk to us about now. Thanks, Sue.
Thanks, Gemma. So there's a paucity of evidence looking at the safety of using valves overnight. Now, the clinical reason for why you might even consider using a valve overnight is that it's unsafe. The clinical reason why it might be considered unsafe is the propensity of the valve to become obstructed in the closed position. So, obstructing the trachea. And the passemeal valve website doesn't endorse the use of a passemeal valve overnight. However, this is not due to the presence of evidence which shows that the practice is unsafe. It's that there are no published studies in adults to date which have shown that it is safe. And many trusts' trachea policies that I can find don't recommend using a valve on overnight, with the justification that secretions or the sleeping position may occlude it. But looking at the pediatric cohort, Barraza et al. In 2014 published a pilot study on the safety of a valve during sleep in children with an age range of up to 18. And the study showed that the use of a valve during sleep was not associated with adverse cardiopulmonary events. And so that was, they say, it's the first study to show that a speaking valve can be used safely during sleep in children. So given that we don't actually have any evidence to date showing that it is unsafe, the question that we need to ask ourselves as clinicians is, why do we want to use the valve for longer periods at night anyway? The assumption, first of all, is that you have a sufficient trachea tube size for effective use of the valve, and that you've tested the patient lying down. So lying down with the valve can sometimes change respiratory function. And often this is when problems with laryngeal anatomy and airway size may declare themselves when patients lie down. The other assumption is that you have got multidisciplinary team agreement to incorporate use of a valve overnight into the weaning regime for the patient. Now, this needs careful discussion, as often, certainly for our cohort, night times are used to rest the patient with the cuff up and to go back onto kind of default ventilator settings. So you may think as a team that there's a time to withhold this practice and opt for daytime valve use only until the patient's vent needs have reduced. In practice though, nighttime valve use is really only mostly considered when the patients are off the ventilator and they're on the ward. A valve can be used, therefore, overnight to extend the tolerance and help build up the respiratory strength at night. And that's when respiration changes, doesn't it? And typically the respiratory rate decreases at night. So it can help, the valve can help test respiratory efficiency at night. Overnight, also, the valve enables normal secretion clearance and it helps airway protection. And so having the valve on enables you to assess those functions when patients are sleeping. And finally, it provides optimum communication options for the patients, especially during those handovers, those late at night handovers, and when patients can call for help. And this is really important for patients who've been used to using a valve all day. So using the valve at night is really good. So I'll kind of just come clean and say that we do use the valve at night here, but we use it judiciously. And there are a few practical things that we think about when considering to use the valve at night. There are three things. First of all, staff vigilance. So are there sufficient nursing resources to provide extra supervision for the patient? Are the nurses confident, competent, and knowledgeable about the processes? Do they know how to troubleshoot? And so I'll always be guided by the nurse in charge as to whether this is a safe thing to do. And there may be a trade-off for the patient in terms of the benefit of using the valve for them as a training tool versus the nurses having to wake up the patient every 4 hours to clean the inner tube. And thirdly, the really practical thing is thinking about humidification, and is that optimal? So we have had a patient recently who hadn't been well humidified in the day and consequently got a bit sticky at night when we started to use the valve and the tube became blocked. The patient was fine, but we needed to double check our humidification. So all in all, I'm really glad that this is a practice that the SEN has been asked to consider, and I would advocate for judicious use of a valve overnight, but it may depend on your patient cohort. And within our hospital, it's particularly useful for neuromedical patients. So our Guillain-Barré patients who need the valve overnight to help with training for their respiratory function.
Amazing. Thanks so much for that, Sue. The next question we had as a SEN, or that we had from people, was that in their units, PMV is considered a communication tool only and a communication device. And we just wanted to have some time to discuss that. So Brenna, thanks ever so much. Over to you.
Thanks, Gemma. This is certainly something that I hear sometimes in our unit as well, that, oh, here's Brenna with her newfandangled ideas again. But actually, I think the conversations that we've already had this afternoon really highlight the benefits of using a speaking valve that are more than just communication. You know, by doing those cuff deflations and using inline speaking valve, we're starting to restore some more normal breathing physiology. So starting to use that upper airway, and all of that information that Annalisa gave us earlier was really helpful in terms of busting that myth about de-recruitment. And in restoring that normal breathing physiology, we're starting to be able to use the larynx and pharynx again. So to achieve vocal fold adduction for coughing and for swallowing and secretion management, and being able to feel those secretions there as well. And the positive impact that coughing and swallowing and managing our secretions has on weaning our upper airways. We also have a few other added extras that we don't think about so frequently, such as being able to smell. That actually being unable to smell is bothersome to some of our patients. And I know some of my patients tell me, oh, my nose feels really uncomfortable and crusty with these secretions in my nose because of the nasogastric tube, and they actually want to be able to give it a good blow and clean it out, which is a really helpful thing when you restore some airflow through the nose as well. There's also your added benefit in terms of the impact on mobilization. So I was having a little bit of a look at a study from Ciron et al., which was published last year, which was talking about that intra-abdominal pressure that we can gain from using an inline speaking valve, and the positive impact that has on our abdominal recruitment. And obviously the impact that has for rehab for our patients, for sitting on the edge of the bed and perhaps doing some standing or other forms of mobilization. I think one of the other myths in that way is around, sometimes we think that we're working our patients too hard to do weaning and to do tasks such as cuff down and speaking valve and rehab and exercises mobilization at the same time, whereas actually there's a benefit to doing some of those things together. I talked just before also about that idea of weaning our upper and lower airways at the same time, that sometimes our teams get into this mindset that using a speaking valve and doing cuff deflation is this communication tool, and we're busy weaning the lower airways, we're busy trying to get them off the ventilator. But actually in neglecting our upper airway in some ways and not allowing that airflow through the upper airways, we're creating a disconnect between that weaning process. And so sometimes you end up in these situations where your patient can breathe and come off the ventilator and they're doing really well with their breathing, but actually they've got copious saliva and upper airway secretions that they can't swallow, they can't cough, their vocal folds aren't as mobile as they could be because they had their cuff inflated for such a long period of time while we weaned the ventilator. I think my final point then on this matter is about the tasks that we do and working with the multidisciplinary team, that actually any member of us from the team can do some of these tasks. They can, anyone can let the cuff down and put a speaking valve on if they know what to do. But it's about how we think about it with our professional hats on and how we do all of those things together to make that weaning and that rehabilitation process as efficient as it could be. And we know from the research that when we do those things together, it's quicker, it's more productive, and our patients feel more confident in us as a team and feel part of that team as well.
Amazing. That's great. Thanks ever so much, all. That's the end of our kind of our myth busting session. We just wanted to whiz through it all. Helen, have you been able to keep an eye on the chat? I'm aware there haven't been any in it, and it might be because you sent lots of your questions in, and hopefully we've answered some of them today. There were obviously lots more about mechanical ventilation, about decannulation protocols and those kind of things, and we've saved all of those up in the idea that we're going to do future webinars.
Just got a couple of last minute questions come in, actually.
Amazing. Okay.
So perhaps the first one from the chat, talking about Patency valve use overnight and whether it would be safe to do this in the community or not, due to the less frequent monitoring.
Sue, do you want anybody want to have a go at?
I'm afraid I'm the wrong person to answer that because I don't see people in the community. I think it's raised a really important safety question. I guess it might be a patient-specific thing. I don't know who looks after that particular patient in the community and whether there are trained carers that can be trained to troubleshoot, whether they're qualified or unqualified.
Yeah, I was going to say as well, probably some of those safety considerations that we would have within the hospital and those kind of very pragmatic conversations about it probably can take place in the community, just as long as they're, everybody's on board and in agreement, and that the patient, the child, it looks like, can be checked throughout the night. So yeah. And
then we've got a couple of other questions. One about the CCHS population. I have to ask, I'm not sure what that abbreviation is. So perhaps if somebody could type in the chat or the questions what CCHS is. But the other one is, someone's asked, do you screen the patients on ICU who are ventilated for trials of inline Patency valve use, or do you wait for referrals? I'm imagining that will be dependent on local practices.
Yeah, in my hospital, we would see all patients with tracheostomies. So essentially, there are no referrals. We would, I mean, we may be even seeing them before. So actually, then we know when they're ready, or have had those conversations very, very early on in order to get there as soon as possible. We even know patients who are kind of due a trachea tomorrow, the next day. So yeah, so that would be the same. Is anybody else? Is anybody getting referrals on the panel?
So we're saying, as you, we see them early, as soon as they start to make decisions to trachea and wean sedation, and that just to reiterate, that is the GPICS guidance that we are involved from the start. So that we can decide or help the team to decide about timing of cuff deflation and passenger valve trials and other interventions.
So our services,
we know that if we are there facilitating those decisions, they happen sooner. We get patients' cuffs down sooner, and their time to talking is dramatically reduced, and time to use of valve is reduced.
Absolutely. Neve, you were going to add to that.
Sorry, just our service is still developing, so we are sometimes relying on referrals from the units to see patients. But I think just to stress that importance of monitoring your patients through MDT trachea ward round, their readiness for cuff down and SLT involvement, and with PMV in line on the vent, and using those opportunities to educate your teams if your service is more in its infancy, is really, really valuable. And then that helps with your referrals, and whether or not you're able to meet that demand, at least you've got an unmet need there that you can use to show data and show that there's need for your service on the unit.
I think it's really important as well that just to highlight about upper airway complications that are so common in this population, in ventilated critical care patients, that mean that a valve is potentially unsafe. And we need to be assessing for that and picking up laryngeal edemas and vocal cord palsies and all of the granulation problems and things that we know are very common. We've got evidence about laryngeal complications that show anything up to sort of 70% of patients have got something not right structurally with their larynx as a result of intubation and other things on top of that. So vestibular valve assessment is so important, that we are there checking the upper airway.
And I think if we're not there, I think what tends to happen is that, I think, and again, this is anecdotally, although, that what happens is it's not successful. So colleagues will try it, it's not successful. Then they might try it again a few days later and it's not successful, but there's no troubleshooting around why patients aren't having success, what the reasons are, what the causes are, because they're not actually, they've not got the right team around them to start talking about that, having conversations, visualizing the upper airway to try and work out why. So patients just keep trialing, keep failing. So by the time we come along, if we're not involved at that initial phase, they're a bit done with it, aren't they? They're a bit anxious, they're not keen, it's not working, and it's all a very negative experience. Whereas I think if we can get in straight away, we can start troubleshooting and problem solving and trying to solve the problem straight away rather than letting it rumble on.
And I think that leads to negativity in the unit about valves, doesn't it? So
yeah, absolutely.
These things don't work.
From. Yeah,
and
absolutely.
then all the problems with, that reluctance to use them, or even to the extent of banning them. And
100%. Yeah. Anything else in the? There are lots of questions now, but I'm struggling to.
So there's thank you very much for those of you who've let us know that it's congenital central hypoventilation syndrome. We are going to pass a couple of PEDS questions over to Vicky Thorpe, who's on the tracheostomy committee and our paediatric specialist, because the panel today we're all adult therapists, unfortunately. There have been a couple of questions on thoughts on how long you would have the cuff down for someone that had no bulbar symptoms. Would you let them go all day?
Potentially, yeah. If there was no adverse signs, there was no reason to take it off. Yeah.
And related to that, how long would you try the Patency valve for your first trial? And I imagine it would be the same if you've got someone that's had a trachea because they've had dental surgery and they've got no problems using a Patency valve and no signs of reason to take it off. You just let them have it.
Yeah.
Right. I think that's it for now. Any other thoughts on that progression from starting the valve to upping frequency or length, or any times that you'd reduce the use of it?
Well, it's bespoke, isn't it? I think that's the key. I think that's the thing that we always say in these webinars and discussions, is about tailor making your decisions about use of the valve and cuff deflation to that patient's wean, to their medical problems and history, and it's going to be different for each patient, but push it as much as you can. I don't know.
Agreed. And I think it's
how long's a piece of string. It's
absolutely. And it's also about the hopefully very educated nursing staff around you also making that call, and saying that actually here are the parameters, or this is what we're looking for. And obviously if a patient's struggling after a period of time, take it off, or give them a rest, give them a break, like they would at any other intervention within the ICU or any intervention, isn't it? But actually as well, I suppose the caveat to that is that then try again, because I think sometimes they might have it on for a few hours and then struggle, and then actually that's it, it's all stopped until we come along again. But it's just about empowering everybody in the team, isn't it, to say, look, this isn't my decision, there's nothing today that suggests that they're going to have X, Y and Z problems, but if you see it later, by all means take it off and reverse what we've done.
I think in the past things were all protocolized, but now it's very much clinically led by how the patient's doing and their background is.
And a great way to do that as well is to make sure that they're around when you're scoping the patient. If you're scoping the patient and taking the valve off and putting it on and seeing the difference, if it makes a difference to secretion management or aspiration risk, and showing the team there and then that this is what the valve is doing, it's supportive of laryngeal recovery, so that they understand it's not a talking valve, it's laryngeal function valve, isn't it?
One of the questions that I know comes up a lot, and certainly comes up within my unit, and about, is there ever a point where too much secretions is too much to drop the cuff? Their suction requirement is so much, their chest is so bad, or whatever, that actually you're aspirating regularly 20 to 30 mils off a subglottic every couple of hours. Is that too much, or what is a guide? Again, patient specific, however.
It also depends on the aim of what you're doing, using the valve for. If it's to communicate end of life needs, if it's to make a decision about pain management, if it's to confirm whether somebody's delirious, then you can't not justify a 2 to 5 minute use of a quick valve.
Absolutely. Yeah.
And about monitoring complications of the aspiration. Are they, if they're aspirating but they're on antibiotics and doing medically reasonably well, that's a different story to someone who's got sepsis, who is poorly, where you'd be more cautious, wouldn't you? So it's just using your dysphagia knowledge as well about weighing up your risks of clinical complications of aspiration, and maybe obviously that looking at as a team at those options for reducing secretion burden. If the patient really can't manage their own secretions at all because they're so severely impaired, what else can you do to help them manage their secretions by reducing secretion burden, like medications, pharmacological options, Botox, whatever, to allow you to get to that cuff deflation, that one-way valve phase as quickly as possible.
Amazing. Annalisa, I know Annalisa is here, but sitting on the street in London because she can't get to a cafe, and is answering some questions in the chat bar that particularly, I think it looks like I don't know, patients, but I can't look at it as well. Anyway, there's some answers to questions there as well. Are there any questions that we haven't
There was one
touched
about,
on or said that we're going to address?
There's one about PEEP values. Somebody wanted clarification on PEEP values. So Annalisa has taught me that reducing PEEP by 5 is a good benchmark to start from, because when you deflate the cuff and put the valve in, you are restoring auto PEEP. So if you're restoring auto PEEP plus the patient's PEEP, you're delivering too much PEEP, and the patient will have to fight against that breath to try and get their words out. So a good place to start is reduce PEEP by 5. So if it's the PEEP of 8, then reduce it to 3 as a starting point.
Someone specifically said, so it's by 5, not to 5.
Yes.
Yeah. Anything else, Helen, in the...
That's all I've been able to see. I hope
Super
I haven't
duper.
missed any, but
super duper. So I was said a couple of times, we'll start to wrap up now. As I said a couple of times in the thing, we had loads that were coming through about kind of manipulation of the ventilator or ventilation questions, and also about decannulation protocols, capping and those kind of things. So we have, we are starting to think about November's webinar, and we are going to sort out a date within the next week or so. So watch this space, but it will be in November, and it will be on decannulation protocols, decannulation weaning, whatever we've got questions for. So watch this space, and we will get the information out to you as soon as possible. Thank you so much for joining us. We always get a really great turnout, and we really appreciate all your support as always with all of this. Thank you to my lovely gang of amazingly supportive colleagues and friends. I appreciate your support and look forward to the next one. So thanks ever so much, guys, and look forward to hearing from you. Take care. See you later. Bye.
Bye.